Welcome to CareTalk, your happy home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
Well, John, I know you got a lot of fancy cars in your various garages, so you're getting a rebate, I'm sure, from your car insurer. But what about from your health insurer?
Oh, David, all of my cars are old, and that's only because the rebate comes from USAA because as my service as an Army reservist. But healthcare, it's strange. But I think it's disorienting. But United Health Plan's rebate to its commercial members is incredibly smart. With at least a quarter of elective surgery and frankly, most ambulatory visits down almost 70%. We know this is going to be a great year financially for the health plans, or we expect that. United is actually taking a leadership position at pushing checks out to support doctors and hospitals that are at risk in this environment. And now they're talking about rebates. I think it's super sensible. It's starting to reclaim the credibility of the health insurer being a good partner.
Well, John, explain this to me, though, because I see, my car's sitting in the driveway. I'm not driving anywhere with it. And when I finally go out and start using it again, it's not like I'm going to make up for lost time by doing an extra fender bender or hitting a tree or whatever I would do. But I also hear about with healthcare, there's all this pent up demand for all these, I got to get my knee replaced or whatever I was going to do before. I'm going to be making up for lost time. So how come the health insurer can give me a rebate?
David, you are such a naive person. When if you look at doctor strikes over time in the last 30 years, whether it's doctors in LA in the 70s, or I believe it was in Jerusalem in the 80s, when doctors go on strike, at least for a short period of time, mortality actually goes down. And a lot of that postponed elective surgery doesn't end up happening. And you're paid annually. If you only have health insurers are paid annually. If they only have 3/4 of direct claims and stuff gets postponed that's unnecessary, they're going to have a big windfall. What this I think will lay bare is care that probably didn't need to happen. I worry about postponing care that should happen, but unlike putting your car in the garage and only driving it when you need to, there's a lot of things that happen in healthcare that are unnecessary.
John, I think that what will happen potentially is that they're giving a rebate now because they realize that for some of their plans, like for the plans under the Affordable Care Act, they're probably going to have to give a rebate anyway because of the medical loss ratio requirement that limits their profitability. But I could see a rebate this year and a big premium boost next year. But maybe we can avoid that if we actually tackle some of these cost trends. And maybe while the tide is out, there can be, new ideas about how to prevent avoidable hospitalizations and overtreatments, and maybe getting care in a less acute and more cost-effective environment. Do you have optimism about that happening?
Well, I think I double back around. I think that the insurers and the folks at United are some of the smarter thinkers long term are wise to think about how resentful a country with 15 to 25% potentially unemployment is going to feel towards insurers that are already necessarily not held in high regard. And I used to be a health insurer, so I understand the disdain that people feel. That when they've got a big cash windfall, it's smart to then reinvest it in goodwill by reducing their costs and also pushing cash out. So I think that's more what's going on. I think it's really hard to predict. I don't actually expect a big jump in trend. If you think about it, post the ACA cost trends actually came down. I think that the bigger question, David, and I guess that I'd ask this of you, is what do you think about innovation? Shouldn't this crisis have created some form of innovation or an innovation bubble? Have you seen any evidence of that?
Well, what I would expect to see is that, there's just initial panic and people taking care of their, making sure their own family life is settled and that they are personally safe. And then you get into innovation. I've seen innovation in things like treatment for COVID itself, where even if you don't have a cure or a vaccine, lots of little things that people are doing and kind of quickly passing information along about. I do think that there will be potentially better use of teams. So we talk about, in primary care office using physician, the nurse practitioner, the nurse, social worker, various people together as a team. I think it's actually potentially easier to do that when you're doing more online visits and you can coordinate better. I expect to see some innovations along those lines, and also about when you actually need to come in versus what you can do online. So I see that. I'm not seeing any like great breakthroughs just yet in terms of care delivery. Are you seeing them? Or are you expecting to see them?
I think you're missing something pretty big. I think this whole explosion of telemedicine is going to be permanent. And underneath that has been a relaxation of state and regulatory requirements. Doctors and pharmacists, organizations that have set the rules at a state level or prevented flexibility at a federal level are all getting pushed back in the need to get more care to people in the cheapest, most effective way possible. I think that's a very big model for how government ought to partner with healthcare to permit innovation with new entrants like telemedicine companies. And I agree with you. I think that the gateway to more collaboration starts with creating more accessibility to information and teams digitally.
John, I think on the telemedicine side in particular, you are seeing some innovation. So a lot of these appointments are just being converted to, you were in person and now you're on just one more Zoom call of the day. But there are some places I've seen success. So one thing I've heard about is this whole question of medication reconciliation. A lot of times people are taking prescriptions that are contraindicated or that just are duplicative or whatever, and they can't remember what they've got. So when you actually can go to your medicine cabinet during the visit and actually pull the bottles out, I think it's actually people are able to do a better job with that. You also see that for certain types of discussions where you want to have a family member there, like if you're talking about end of life discussions, or you're with somebody that may have some confusion, or you're making a decision about a surgery, it's easy to bring other family members into the conversation, even if they're not there with you, and even sometimes bring other medical specialists or social workers, on the line. And then another thing I think is that a lot of what happens, you're in the physician office as a patient, and you're being assessed in that environment, but that's not your environment. So if the provider can actually see what it's like in your home, they may have a better sense of how things are going and may be able to tailor a treatment better or get some sort of insight. I see those sort of things happening on the telemedicine side.
So the digital doorway is open for U.S. healthcare for the first time in a meaningful way. Do you think it stays open post the crisis?
I do, John. The reason I think it does is because I think the crisis goes on for some time. This isn't just like a hurricane or tornado or earthquake where they just sort of open things up on an emergency basis and a few days later it's done. We're going to have this with us, whether we like it or not, for some time. And that's going to be long enough for habits. That's going to be long enough for evidence. And I think what's going to occur is that you might not have exactly what we have now, which is that any kind of visit is reimbursed the same as an in-person visit, be it a phone call, be it a televisit. I think there can be some adjustment and some learning about how it works. But yeah, I don't think we're going back to how we were. I'm pretty sure of it.
I think there is a permanent change in the way people think about the risk of being in hospitals and nursing homes, being in institutions, going to the doctor's office. And I think that's going to reflect more consumer demand for digital delivery and access. And I believe that, for the next 24 months, I think you're going to see the volumes stay down because of exactly what you said. I think it's years before folks get comfortable with going back to sort of the pre-March shutdown levels of care. So I think this is a profound change to the system, and it's going to help the fact that the digital doorway has got to turn into a digital highway for healthcare.
Well, John, we're about out of time. So for now, I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for joining.
Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.